So in today's session, first of all, we're going to talk about our special courses that we have designed for all of you who are preparing for FOP and TAS. So in that course, we are going to cover all the notes, all the things that you will be needing for your preparation. And then Dr. Nida is going to explain it to you, all the important recalls for FOP preparation. And then Dr. Aashna Verma is going to join us and she is going to share all the important recalls that we can solve for the TAS preparation. So now let's talk about the features that we are offering in our FOP TAS crash course. So in our crash course, what we are going to do is we will be having interactive live session. In those live sessions, we are going to focus on all the important scenarios and all the important recalls that you will be getting in your exam day. So on those live sessions, we will be solving the maximum questions that we can so that your all concepts are cleared and all your scenarios that are going to come in your exam day will be cleared for all of you. And then after the live session, we are going to provide you the recording. So in case all the students who were unable to join the live session, they can get the recording of the live session along with the slides as well. And then with the live sessions, we are also going to provide you the question bank that will contain 2,000 plus questions for FOP and 2,000 plus questions for TAS separately so that you can practice maximum questions as you can before your actual exam. And then after joining the course, you will be added into the study group. In the study group, we are going to solve daily wise questions. If you have any questions, you can ask the mentor directly as well. So we are going to hold activities in the study group. And then by the end of the course, we're going to provide you the mock exams that will really help you to boost your energy so that you can have a real-time experience before your actual exam. And then for theory help, we are going to provide you the notes, we are going to provide you the books, the important files that you can use for your theory purposes. So these are all the features of the course. If you want to join the course, our team is also there. So just directly give us a message and our team is going to guide you about all the course features. Now, let me quickly give you a tour of our website so that you can know what we are offering in the course. So this is the view of our website. So once you log into your account, then you will see these options. You have to click on user dashboard. So if you join the course, you will click on user dashboard and you will see the courses that you have enrolled in. So let's look at the tour of our course. If you join the course, then you have to see the screen on your website view. And then in the course material, you will see course content, you will see notes, you will see topic tests, you will see recordings, you will see downloadables. All these stuff will be provided to you once you join the course. So in the notes, let's suppose if you want to read any note for any topic like health medicine, like cardiology, like anatomy, like any topic that you want to read and you want help in the theory, then we're going to provide you all the notes that you can use to read and to get help in your theory. So now let's check the topic test. If you want to, you prepared any topic and you want to practice the questions, then you will see all the questions in the topic test. We have separate tests for each and every topic that is important for your preparation. Then in the recording section, we are going to upload all the session recordings that we are going to conduct. Like whenever there is a live session, on the very next day, you will get the recording of that session and you will see the recordings over here in this module. So let's go back to the course dashboard. If you want to access the question banks, so we have, as I told you before, we have separate question banks for FOP and separate question bank for TAS. If you want to access the FOP question bank, you have to click on that. And then you will be able to see the question bank of FOP and you can practice as much questions as you can. You have to click on practice now. You will see two modes that you can use to practice your questions. You will see revision mode and you will see mock exam mode. In the revision mode, you will see a correct answer and explanation with each and every question that you want to practice. And in the mock exam mode, you will see a proper exam with proper timer in which you have to perform the questions. And after performing the questions, you can see your score. And after checking your score, then you will be able to see your answers and explanation. So this was the tour of our course. So now I would like to request Dr. Nida, are you here?
Yes, I am.
Yes, Dr. Nida, can you please share your screen so that we can start the important recalls for FOP?
Yeah, thank you, Asma. Thanks for brief explanation of our website and all. I'm very glad. So first of all, I want to say hello, good morning, and good afternoon to all of my listeners. I am here. I'm very excited to present myself as your mentor, as a foundation of practice mentor. I'm Dr. Nida, one of your mentor here, and today we will discuss here all the tips and tricks, how to solve the recall, how to solve the best of one questions for the foundation of practice. So I want to tell you that before starting our recalls and MCQs, I want to tell you that don't go exam before solving the clinical cases. This is 50 clinical cases, and in each recall, we will discuss the clinical cases along with it. So you will get an idea that what exactly they want to ask. So first of all, just this is a today we will discuss about the nutritional recall. So we will I will give you the overview regarding what they are really interested to ask. So this is a clinical case, and I want to read it for you, and anyone can answer. So please answer. Open your mic and answer it. So, is a clinical case of FOP, a 2 months old breastfeed boy present with a long history of crying after feed, being generally unsettled with loose stools which have been bloody on several occasions. He was born 39 plus 5 weeks following a normal pregnancy, weighing 3.4 kilogram, has been breastfeed from the birth and prescribed sodium alginate by his GP for reflux disease. He is regular emollient for eczema. On examination, his weight 6.6. He is alert and responsive. He is unsettled and crying when you examine him. His heart rate is about 130 beats per minute. Capillary refill time is 2 per second. And apart from some moderate eczema, his systemic examination is otherwise L. Well, so you might come across some distraction also. They are creating some distraction also. So what is the most appropriate first line investigation? Can anybody answer it? Okay. So actually, in this case, the correct answer is a yes. Who answered it? And well, this is not for the ultrasound abdomen. Say few topics they like most. Among them, the cow's milk protein intolerance is the favorite one. So for regarding this scenario, the correct answer for that is uh, trial of maternal dairy free diet. So if you will eliminate the dairy free diet from the maternal side, then you will overcome this problem. Now, next solve the next clinical cases. Is a clinical case number 50. Okay. You are seeing a patient in primary care practice. Oliver is a 6 weeks old baby who is brought for his routine infant examination. He was born at term weighing 3.4 kilogram, with his weight now being 4.5. His routine examination is normal. His mother is concerned about his weight. He wakes for breastfeed for every 3 to 4 hours and falls asleep after a feed. He has a good sucks and feed for 10 to 15 minutes. On weighing his growth, his child health record, his only record weight is about 2 weeks of age. So only one record is given to you when it was on 25th centile. Which of the following is a most appropriate next step? Okay, so can anybody answer this question? Question number one. Um, C. Okay. The correct answer is vitamin D supplement, not only for the Oliver and also for his mother, because both are deficient. Now, go ahead. Oliver remained well, but age 2 years. You can see in pediatric clinic follow a referral by his GP. Please, can you see Oliver who is sleeping and a lot and is less active than usual? He is awake. His stools are variable between constipation and diarrhea. He drinks 2 bottles of formula milk per day and eats a varied diet. He is not only and not on any medication or supplement. On examination, weight is 9.1. He is 2 years, remember it. And he's a dermatous rash and cracked skin as his angle of his mouth. Like he has cheilitis also. And his swollen wrist. So what does it mean, swelling wrist? That the rickets is also developed. And he has developed a rash around his mouth. On examination, she has also reported that his wrist appear more swollen. So full blood count is noted. Hemoglobin 72 gram. They usually measure is gram per liter. MCV is 70 femtoliter. Platelet count is 4 lakh 25. Neutrophils 3.5. Lymphos are 4.5. So what nutritional deficiency is likely both based on the Oliver symptoms and sign? Can anybody answer? So he has cheilitis and he, yes, yes. It's C. Yes, it's C. He has iron deficiency and vitamin D. Iron because of cheilitis and vitamin D because of he is developing rickets. Now, what is the most likely cause of Oliver symptoms? Can anybody answer it? So why the child is 2 years of age and he is developing loose motions and constipation and swelling wrist and signs symptoms of failure to thrive. So all these signs are going towards that he is developing a problem maybe. Can anybody answer it? Option A, B, C, D, E. Yeah, yeah, it's C. Yeah, yeah, no. He is developing a disease that is a celiac disease going toward, although he is dietary deficiency and going toward the celiac disease. So the concept of asking to solve this clinical case that give you idea about that what they are interested. They have some specific topics that they will not, let you go. You have to, focus on that. So now we are solving our nutrition recall. Okay. So please participate as much as you can. Which of the following is true of cow's milk protein intolerance? Okay. This type of questions they usually give. Sometimes the foundation of practice questions are very easy. You don't have to think about a second. But sometimes they are very tricky and very close. Sometimes two options are very close. So which of the following is true of cow's milk protein intolerance? Cow's milk protein intolerance. Option A, option B, option C, option D, and option E. Can anybody answer? Mm-hmm. D, one half of children will not have symptoms. No, it's not correct. Harshika, anyone? No, no, it's not. No, it's A actually. This is affect about 5% of children. It's about the data. So option B, option C, and anaphylaxis can see in the cow's milk protein intolerance. So let's move toward the second one question. Which of the following is true about the cow's milk protein intolerance? Blood in the stool, option A, should lead to further investigation and consideration of alternative diagnosis. The negative predicted value of the skin prick testing specific IgE for immediate reaction is not diagnostic. A positive atopic family history is common. Less than 30% of children with positive IgE tests have a positive diagnostic of cow's milk protein. An oral food challenge should not be tried in the children. With cow's milk protein and diagnosis should be blood test and exclusion criteria. So what do you think? Any if you just recall your memory, there just we solve a clinical question. There is a topic family history is common. So in the clinical cases, option yes, option C, yeah. In the clinical cases, they told you that in that boy, there's a history of atopy in the family. So the option C is correct. Okay, this is very easy question. I think everybody know it. The body mass index is calculated by, please answer. Doctors, please answer it. It's very easy. Sometimes in foundation of practice, you may come across very easy question. Even you don't have to think. Okay. Yes. Yes. The option A is correct. So yes, everybody. Yeah. Okay. So this question, which of the following is not in extensively hydrolyzed formula? Cow and get Pepti Junior. The second one, option B is Progestimal. The C is Nucate LCP. And option D is Eptamil Pepti and Nutramegen. Which one? C? Okay. Uh, okay. Yeah. The C is correct because mill engine. There's a there's a trick. Mill engine most of the time, except the isomill. Okay, so these are the extensively hydrolyzed formula milk. So extensively hydrolyzed formula milk is that type of milk that cannot be deducted by the body. And yeah. Harshika, you are right. This is Nucate LCP. So, so there is a description about that. Let's solve. Which of the following dermatological manifestation is not commonly seen in cow's milk protein intolerance? Topic eczema is very easy. You will take, I think, seconds, then you can solve it. Seborrheic dermatitis, erythema, and acute urticaria and acute angioedema. Yes, yes. So that type of straight questions also come and it will save your time. Okay, now solve this one. A 15-year-old girl attend clinic as her GP concerned that she has not been eating. She is 50 kilogram and 165 centimeter tall. Select her BMI for the following. Who answer it very quickly? B. B. Jamil Shah B. Okay. So the calculation of BMI is like that: kilogram divided by meter square. So you have to convert the centimeter. If you will remove the decimal, then it 1.6. So square that 50 divided by 1.6 into 1.6. It will almost to 50 divided by 2.5. So roughly you just calculated it's around 20. So it's more than 18. Yes, 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 you are right. Arshika, yeah, you are right. Kimika, you are also right. Which of the following is not a features of cow's milk protein intolerance? So failure to thrive, angioedema, oral itching, and steatoria. So of course, the option E is correct. Steatoria is not a correct option. Now, which of the following findings suggest an IgE mediated cow's milk intolerance rather than non-IgE mediated cow's milk intolerance? Okay. So I want to tell you regarding the IgE mediated, it's rapid onset, and non-IgE mediated, it's lasts for 48 hours till 2 weeks. It can last. So here the recall for answer is oral itching. Okay, which of the following is not associated with pellagra vitamin 3 deficiency? Anybody can answer. Dermatitis, glossitis, diarrhea. Okay, weakness and tachycardia. So regarding this pellagra, this 3D, always remember 3D: diarrhea, dermatitis, and dementia. Okay, if you remember this, you will never ever forget this. So tachycardia is not the feature. Who answered it? Tachycardia. Option E is correct. Okay. So, which of the following is only suitable for children over the age of 4 years? Okay. So, we prefer this rice milk is more favorable for the age of 4 years. So, question number 11. Which of the following may be tried first line in a 5-month-old with suspected cow's milk protein intolerance? So, we know that this under 5 years of age, we cannot start this soya milk. So this answer actually is we can start this infa soy. Sorry. So we can start this progesterone. Here the option is here. Which of the following is true for vitamin A? Option A is vitamin A deficiency is a major cause of cataract. No, it's not leading cataract. Vitamin B. We have option number B is a water soluble. Option C, it can causing spina bifida in the developing fetus in pregnant. No, it's folic acid intake of vitamin A. Option D is sweet potato, squash, pumpkin are good dietary sources of vitamin A. Retinol, pantothenic acid, retinoic acid, and beta carotene are all forms of vitamin A. So the option D is correct. I think I missed that one. Question number 13 is which of the following is true of neonatal nutrition? The term infant required 70 to 80% Kelvin calories day of breastfeed. The term infant required 50 to 60 Kelvin calories day of formula milk. Premature babies required additional 50% calorie intake, and the ideal energy ratio is nutrition is 60% of carbohydrate and 35% of lipid. Energy requirement reduced. No, it's not reduced 30% between 6 to 12. So for the neonatal nutrition, the ideal energy ratio is about 65% of carbohydrate. Here's a description of all questions. You can read also. Okay. Now, which of the following may be tried first line in 5 months with suspected cow's milk? Okay. Anybody can answer? Yes, answer is already here. Yes. Okay. Which of the following is suitable for 10 months with okay. So question number 17. Which of the following statement regarding obesity is true? The answer is also here. Just want to tell you that 10% of obese children have underlying hormonal, genetic, and medication related causes. Macrosomia is not a risk factor. IUGR is a risk factor. BMI of 91% is obese. It's not obese. BMI more than 91 is underweight. Childhood obesity can decrease the life expectancy. No. So 80% of teenagers who are obese are going to go on to obese as adult. Okay, which of the following is not extensively hydrolyzed formula? So, this one is came so many times and so many times has been asked in the previous recall. So you have to memorize which one is extensively hydrolyzed formula, which one is amino acid one. So this Nutramegen is amino acid one. Okay. Question number 19. Which one of the following vitamin deficiencies paired with correct result in clinical problem? So vitamin A deficiency and pelagra, vitamin B3 deficiency and scurvy, vitamin C, harvardix, and vitamin D deficiency. and vitamin B1 deficiency in beriberi. So it is a very beautiful note about the vitamins and diseases. So just memorize this. Question number 20. Which of the following is true of cow's milk protein intolerance? Mammalian milk substitute are nutritionally adequate. Extensively hydrolyzed formula do not cause reaction as a cow's milk protein are broken down. Soya milk is less allergenic than the extensively hydrolyzed formula. And the skin prick testing toward the milk is positive majority. No, it's not all time. So elimination diets need to be followed for a minimal of 60 weeks. So extensively hydrolyzed formula do not cause reaction through the cow's milk protein are broken down. So this is all the recalls that we solved together. Okay. Okay. Thank you.
Hello, everyone, and let's get started with the TAS call session, and we'll be discussing important points in the session. And so we have quite a many questions. Let's get started. So the first question says, I'm audible, right, Aashna?
Yes, ma'am, you are audible.
Okay, thank you. Okay, so the first question is, a newborn with temperature 38.7 degrees Celsius, irritable and high-pitched cry. The blood CS and CSF shows gram-positive bacilli. What is the organism? Okay, so to solve this question, okay, so meanwhile, you guys can, write your answer in the chat box so that, you have a fair idea if the answer is correct or not. And I the answer so that your mind doesn't change answer after knowing the actual answer. Okay, we tend to do that. When we get to know the answer, we think, okay, I was also thinking the same, but that's like, let's be true to ourselves. You can mark the answer and then we'll discuss, what went right and what went wrong. So to solve this answer, I would want to tell you that newborn sepsis is a very important topic, and the organisms related to it are being asked, more or less every year, and in every or alternate diets it is asked. So know that newborn sepsis can be of congenital type, it can be of early onset, and it can be of late onset. Congenital, that when it is present since birth, and it is early onset when it occurs less than 72 hours after birth, and it is late onset when it occurs more than 72 hours after birth. Okay. Now, neonates are particularly susceptible to some pathogens which have polysaccharide capsule, for example, group B, Streptococcus and E. coli, and especially these organisms because they have low levels of complement and impaired oxidation process in their body. Okay, so that's why we will see that some organism cause, they become more common cause of newborn sepsis compared to others. So yes, the early onset sepsis that we talk about mostly is acquired from the maternal ascending infection or during the passage through the birth canal. And the very common organisms that we see are group B streptococcus and other gram-negative organisms, Listeria monocytogenes and Staphylococcus. Okay, that comes late onset infection, which occurs after 72 hours of life, and that is mostly nosocomial. Okay, so this is how classifying newborn sepsis into early and late helps us. When we classify them in this way, it helps us plan the management, because in all cases of early onset septicemia, we'll be suspecting the above given organisms and starting the antibiotic, whereas in cases of late onset septicemia, where we know that the most common cause is nosocomial, that is hospital acquired or community acquired, we think of other organisms which are more common due to these pathophysiology, that is, hospital acquired or community acquired. So here in late onset, we have group B streptococcus infection again, which is the most common one. Okay, it is common in early also and late also. And yes, we have cons too. So the most common cause of late onset sepsis in low birth weight baby is due to cons, that is coagulase negative Staphylococcus. And it is known to produce a biofilm that facilitates adherence to lines and catheters. So whenever you are given in a question that a baby who is having long lines since a long time, maybe 7 days, 10 days, and then they have acquired septicemia, in those patients, we suspect Cons infection, okay? And also in some exam, you can be asked about the pathophysiology, how the Cons become more common in case of patients having lines and catheters. So yes, this is important, pathology behind it. That is, they form biofilm that facilitates adherence to lines and catheters, okay? I hope it is clear till now. Now, coming to the question, okay? See, the question is asking us about a condition of newborn sepsis. And the hint that they have given here is not about late or early, okay? They have not even mentioned how old the baby is. They have just written some symptoms, and that the blood CS and CS is gram positive, okay? Gram positive bacilli. So we'll be solving this question with the help of this table, okay? Okay. So this table is a classification of microorganisms which are important in our medical setup. And they have been classified according to the cell wall they have, that is rigid, thick walled cell, or some having flexible, thin walled, who are wall-less organisms, okay? So the most common type is the one having rigid and thick walled cells, and they include all the free-living extracellular bacteria, which we commonly hear, and then some of them are, acid-fast bacilli, and the others are intracellular parasites. Okay, so coming to what is going to help us in fetching the answer is, see, I have marked gram-positive organisms, and they are classified into those who are cocci, the others that are spore-forming rods, and the other that are non-spore forming rods. Okay, right. So in question, we have not been mentioned about spore forming or non-spore forming. We just know that it is a gram-positive rod. Okay, so here we have the list: bacilli, clostridium, corynebacterium, listeria, actinomyces, and nocardia. Okay, so these are the ones who are gram-positive, and they have rods. Right. Then look at other organisms who are common in causing newborn septicemia. So we have streptococcus and staphylococcus. They are gram-positive cocci, okay, but they are cocci, so they are out of the question. And we have organisms like Escherichia coli. Okay, you can see it in gram-negative rods. Okay, it is enteric and related organism. So yes, it is a gram-negative rod. So that is also out from the option, right? So going back to the question, you can see newborn with temperature 38.7 degrees Celsius and blood CS and CSF showing gram-positive bacilli. So the answer would be Listeria monocytogenes. Okay, Listeria monocytogenes is a gram-positive organism, and it is bacilli. Okay, it is in bacillus form, right? Group B Streptococcus is cocci, and E. coli is a gram-negative rod. Okay, right. And talking about Haemophilus is again a gram-negative rod. Okay, so that is also not the right answer. So I hope you have understood how we came to this answer. Right, but see, this is one sort of question where the clinical scenario wasn't important. It was just the gram-positive and the nature of the organism which helped us fetch the answer. But in some cases, they do give you a scenario in which there is a baby who is born out of and they ask you what can be the possible organism causing the septicemia. So in those cases, Listeria be the answer. In long line in situ, as I told you, cons become an important cause because of the biofilm that they form in the catheter. So yes, that is the cause there. And in case of PROM, GBS again is a common cause, group B Streptococcus. And if you are given a case of galactosemia causing septicemia, so there E. coli becomes an important cause, and infective endocarditis is caused by Staphylococcus viridis. And most of the septicemia, which are occurring less than 3 months of age, they are due to group B streptococcus. So here are some key words and the related organisms which are found positive which are seen positive in these cases. So anytime you see these keywords in the question, do look for the organisms which I have given in the table to you. Okay, this is a very, very important table. Right. So coming to another question and a very favorite topic of TAS, that is pharmacology. So the question says, drug administered IV, which one is true about first order kinetics? Okay, so let's see the options that we have. Rate of elimination is dependent on plasma concentration. Okay. Doubling dose will result in doubling the duration of excretion. Increasing the dose will result in side effect if metallic enzyme or excretion routes are saturated. Increasing the dose will increase the volume of distribution in a steady state, and doubling the dose will half the time taken to regain steady state. All right. Okay, so let's talk about first order and zero order kinetics. Right. So in first order kinetics, the chemical reaction takes place in such a way that the rate of reaction depends on the molar concentration of one reactant. Okay, so the concentration of the reactant is determining how fast it is being metabolized. Okay, whereas in zero order kinetics, the chemical reactions does not depend upon the. So in zero order kinetics, the metabolism is not dependent on the reactant concentration, whereas in case of first order kinetics, the reaction depends on the concentration of reactant. Okay, so this is the major definition of first order and zero order kinetics. So let's see further. Graph of the reactant concentration versus time is a curved graph. Okay, whereas in case of zero order kinetics, the graph of reactant concentration versus time is a linear graph. So as time passes by, the amount of this reactant which is being metabolized remains, same. So it is a linear graph. It does not increase or it does not decrease. Right. Then the rate of metabolism is proportional to the drug concentration in case of first order, and in case of zero order, the rate of metabolism becomes independent of the drug concentration. The rate constant multiplied by the reactant concentration, and in case of rate law includes only the rate. Okay, so here again this line means the same. Okay, here the rate constant would be multiplied by the concentration of reactant. So again, that is an important determinant of the rate, and here it is just the rate constant, okay, which is determining the rate of the metabolism and not the concentration. I hope I am being clear. Then increased plasma drug concentration increases rate of drug metabolism. So yes, this is an important point. When we most of the times get confused with this option, which is most commonly given in such type of question. They'll ask you if we increase the amount of metabolite or the drug to be metabolized, then the rate of metabolism will remain same or will decrease. These options are given to you, but be clear with the fact that if there is increase in drug concentration, there will be increase in the rate of drug metabolism. Okay, right, and they'll increase proportionately. So in case of zero order kinetic, increased plasma concentration, there will be no increase in rate of drug metabolism. The rate of metabolism of the drug will remain same as it was before. Right. And then last comes the most important point, that is in first order kinetics, the half-life is constant. Okay, half-life is constant, and half-life is time to metabolize 50% of the drug. And in zero order kinetics, rate of drug metabolism is constant. Okay, rate of drug metabolism is constant. Right. So let's see what will the answer be in this question. So rate of elimination is dependent on plasma concentration. In case of first order kinetics, yes, this is the right answer. Second option says doubling dose will result in doubling the duration of excretion. No, it will not double the duration of excretion. The duration of excretion, that is the half-life, will remain constant, okay? And increasing the dose will result in side effect if metallic enzyme or excretion routes are saturated. This is not the case in first order kinetics, but this is the case in zero order kinetics. This statement holds true for zero order kinetics. Increasing the dose will increase the volume of distribution in a steady state. No, this is not the right answer. Volume of distribution depends on other factors also. And doubling the dose will half the time taken to regain steady state. No, this is also wrong option. So option A is correct for question 2, okay? Rate of elimination is dependent on plasma concentration, right? So we have a similar question here related to half-life cycle, okay? And this was one of the recall which was asked in recent exam. So how many life cycles are required to eliminate 97% of the drug from circulation? Okay, they're asking about the number of half-life cycles. So half-life, as I told you initially in the previous slide, that it is time taken for the drug concentration to decrease by half, okay? So how much time is being taken for the drug concentration to decrease by half is what your half-life is all about. So here I have given you this. Let's start from 100% of the drug. So from 100% to become 50%, it is taking one half-life, okay? One half-life cycle is being taken for it coming from 100% to 50%. From 50% to 25, it is taking 2 half-life cycles. From 25 to 12.5, 3 life cycles. From 25 to 6.25, 4 life cycles. And from 6.25 to 3.1%, it is taking 5 half-life cycles. So when you have 3.1% of the drug remaining in your body, okay? So how much of it has been eliminated? Almost around 97% of the drug has been eliminated, okay? So in this question, they are not asking you how much amount of percentage of the drug remains. They're asking you how much drug has been eliminated, okay? So it is 100 minus 3.1, that is 97% is left after 5 half-life cycles. I hope this is making sense to you. If you have not understood this, please make sure that you write to me on the chat box so that I'll see all your doubts together. Okay. Right. Okay, moving on to the next question. It is also, I have taken this question as an additional one. So as to tell you the similarity, the similarity in the questions that are being asked for TAS exam. But see, this question was asked in one of the diet and this question was asked in next side. Okay. But most of the students think that the questions are being repeated, but see, they repeat the topic, they repeat the concept, they do not repeat the same question. Okay. So this is why understanding and clearing your concept becomes important. Okay. So this is another question related to half-life cycle, and it says half-life and elimination of drugs A, which is a new antibiotic. Sorry, half-life and elimination of drug A, new antibiotic X has been developed. It has exceptional antibiotic activity, but is toxic in higher dose. The half-life is 2 hours in children. Okay. So they have given you that the T half is equal to 2 hours. After how long will 97% of this new antibiotic X be eliminated from the child? Select one answer only. Okay. So now they are asking you the number of hours being taken. They are not asking you how many life cycles takes to eliminate 97% of the drug. They're asking you for your drug to be eliminated by 97%, how much time is it taking? So in this can be answered with the concept that we have already discussed in the previous question, that For eliminating 97% drug, we are using 5 half-life cycles, okay? So this question can be solved with just a click that 5 into the time which is taken for 1 half cycle, that is 2 hours, okay? So 5 into 2 is giving you the answer, that is 10 hours. I hope this is clear to you, okay? So I hope you guys are understanding how half-life cycle is an important concept, and you need to know it thoroughly to answer these questions. So they have changed the way of asking the question, if you can appreciate that. So again, I have incorporated this extra question just to explain you how they are, making question on the same concept. So the question says, half-life and elimination of drug A new agent has come to the market as a treatment for severe pain. It is intended to be given as a single dose rescue treatment. There have been no large studies in children, but in the literature, its plasma half-life is 12 hours. What percentage of the dose is steady in the body after 1 day? Select one answer only. Okay. So according to them, the plasma half-life is 12 hours. Okay. And they're asking what percentage of the dose is still in the body after 1 hour. Sorry, so 1 day comprises of 24 hours. Okay. So your 50% of the drug is eliminated in the 12 hours. Okay. So after a day, 25% is only left in the body after 2 half cycles. So as you can see, the half-life which is given to you here is 12 hours. So once 2 half-life cycles are gone, that is 24 hours are gone, we are just remaining with 25% of the drug. Again, it can be explained with the same concept that we have discussed here. For the drug to become 50%, 1 half cycle is being required, that is 12 hours. For drug to come down from 50 to 25, second half life cycle is required, that is 12 hours plus 12 hours, that is 24 hours. So after 24 hours, we have 25% of the drug left with us. I hope you are clear with the concept that we are talking about in these questions, okay? So I have, intentionally included these similar questions so that you understand that the same concept is being assessed in different ways, in different exams, in different settings, and you need to be clear with all your facts and concepts. So coming to the 4th question, fat-soluble vitamin out of the following is, okay, I think this is an easy question for everyone, but still, let's see. Fat-soluble vitamins includes A, D, E, K. Okay, so A, D, E, K are the fat-soluble vitamins, and all other vitamins are water-soluble, which includes B complexes and vitamin C. Okay, so the answer to question 4 is vitamin D. Option E, vitamin D. Okay, this was an easy one, but they have framed a similar question for around 2 to 3 times in different diet. Right. Question 5. 3 days old baby presented with poor feeding, lethargy, blood test suggests metabolic disease. Okay. And which congenital enzyme deficiency suggests X-linked recessive inheritance. Okay. Now understand the fact that in this question, they have not given the clinical scenario in such a way that you can make the diagnosis based on the clinical scenario. Okay. At the end of the day, in TAS exam, they are trying to assess your pathology, your pharmacology, your basic sciences that is, required to understand a topic. So again, in this question, you are given a clinical scenario, but that clinical scenario has incomplete details to make diagnosis based on, the clinical hints. Here, you have to make diagnosis just based on the pattern and the type of inheritance that has been given to you, that is X-linked recessive inheritance. I hope you can appreciate the difference between the kind of questions that you are being asked in FOP exam and TAS exam. Okay, right. So you have been given these 5 options, and let's see, which of the following is X-linked recessive, because that is going to be your answer. Okay, trust me, there is no clue in the clinical scenario which has been given to you, because it can be seen in all the conditions given below. Okay. Right. So X-linked recessive disorder, these are the examples that you have with you. And please memorize these examples, because they, ask questions related to pattern of inheritance. It is a very common question that is being asked in TAS exam. So I want you all to learn these examples of X-linked recessive disorder, because X-linked recessive and X-linked dominant question becomes their favorite, okay, because they are selected number of disorders which come under these categories. Hence, they are the highlights. So here you can see that ornithine transcarbamylase deficiency, that is OTC, is an example of X-linked recessive inheritance. So option B becomes answer to your question 5. Option B, OTC, is the answer. Okay. And how have we arrived to the answer? After looking at these examples given to you. Okay. Right. So let's talk about X-linked recessive inheritance, because they also happen to ask you pedigree chart, and maybe some in a next slide they'll give you a pedigree chart and they'll ask you to select one of the disorder which shows this kind of inheritance. So in that case, you'll have to first see the pedigree chart and tell if it is X-linked recessive or X-linked dominant, and then you have to choose one of the disorder which falls under the mode of inheritance which have been given to you. Okay. So yes, X-linked recessive inheritance, in this, the males are affected, okay, and females are the carrier. So you can see a circle and a dot within shows a carrier state, which the females are, and they are passing it to their son. Okay. So males are affected and females are carrier in X-linked recessive inheritance. This is an easy one to catch. Okay. Coming to, this is another example of X-linked recessive inheritance, which is given in your science of pediatrics. And mothers of affected boys are often carrier, and this condition is not transmitted from a father to his son. Okay. Right. So let's talk about X-linked dominant disorders also in this sitting only, because as I told you, X-linked recessive and X-linked dominant disorders are their favorite. Okay. It is their like go-to questions when it comes to TS exam. So these are the examples of X-linked dominant disorders. And yes, my dear friends, I would want to tell you that some of these conditions like Fragile X syndrome and Alport syndrome, they do show other kind of inheritance pattern also. Okay. Like Alport syndrome is a disorder which has X-linked inheritance, X-linked pattern of inheritance. It is X-linked recessive also, and it is X-linked dominant also. But most of the scenarios, most of the studies have shown that it is more of X-linked dominant than X-linked recessive. Hence, we have this example here. Okay. So Alport syndrome is as most commonly X-linked dominant inheritance, right? And the other conditions are X-linked hypophosphatemia, Rett syndrome, incontinentia pigmenti, and Fragile X syndrome, Charcot-Marie Tooth disease. Okay. So these are your examples for X-linked dominant condition. And here we have pedigree chart of X-linked dominant. And I have intentionally kept the pedigree chart of autosomal dominant beside it, because these are the two which are most commonly confused. Okay. I have been at your place in the recent past, and I know that these two are a little confusing, but I'll tell you that because it is a dominant condition, you will see that there are affected cases in every generation. Okay. This is common for both the X-linked and autosomal dominant condition. But in X-linked dominant condition, you will see that X-linked dominant, none of the males, okay, none of the fathers are passing on this disease to their sons. Okay. Fathers are passing this condition to their daughters. Mother are passing this condition to both their sons and daughters, but fathers are not passing this condition to their son, because a father is giving Y chromosome to son, and the X chromosome of the son is from mother. Okay. So if a father is having X-linked dominant condition, that X is not going to the son. Hence, they are spared. Okay. Whereas in autosomal dominant condition, that you can see that fathers are passing disease to their sons. Okay. I hope you have got the trick to identify X-linked dominant and autosomal dominant. Okay. So I want none of you to make this mistake in your exam. And yes, we are done with X-linked dominant, autosomal dominant, and X-linked. We'll be discussing more of these conditions in the genetic session that we'll be taking in the upcoming course. Okay. And this is again the similar picture of X-linked recessive inheritance. Okay. Where the mothers are passing disease to their sons, and yeah, mothers are the carrier. So coming to the next question, question 6. In embryology about her disease, which one is true? So the options are failure of migration of neural crest, apoptosis of the intestinal ganglion, in utero interruption of the mesenteric blood supply, intestinal neuronal dysplasia, or congenital neuroapoptosis. Okay. So talking a little about Hirschsprung disease. Hirschsprung disease is very important. And this disease is so important that they ask this in TAS, FOP, and then eventually you will see similar questions in AKP, and then in your clinical exam also, okay? Right. So talking about the pathophysiology, this is a congenital condition, okay? So there is congenital absence of ganglionic cells at the Meissner's plexus, which is submucosal plexus, and Orbash plexus, which is muscularis plexus, in a variable segment of the bowel. Okay, so there is aganglionosis. Okay, and it occurs as a result of failure of migration of the neural crest. So the neural crest, because they have failed to migrate to these areas of submucosa or muscularis in the segment of the bowel, which is mostly in the lower part, the sigmoid of the rectum. This is leading to this aganglionosis condition, which is known as Hirschsprung disease. Okay, the sigmoid and the rectum are the most commonly affected site, although it can involve variable segment of the colon and sometimes the small bowel also. But most of the time, when you are given a clinical scenario, they'll make sure that they're talking about the classical presentation, which is mostly with the involvement of sigmoid in the rectum. Okay, but yeah, there can be long segment Hirschsprung disease involving the colon and sometimes the small bowel also. Okay, right. The lack of ganglion cells causes an inability of the bowel to relax, resulting in functional bowel obstruction. And yes, they do give this in the clinical scenario that when we have a baby who has not passed meconium for the first 48 hours of life, we suspect Hirschsprung disease in them. And in infant who, they'll give a scenario of infant who has presented with bowel obstruction, and initially during the newborn period, there is also history of delayed passing of meconium, right? Also, sometimes they give this on examination sign, that is on digital examination of the rectum with there is explosive diarrhea, okay, because there is transient dilatation of the bowel because of your perrectal manipulation. There is explosive diarrhea that is occurring. Okay. Now, for investigation, we go for rectal suction biopsy. That becomes the definitive diagnosis, which shows absence of ganglion cells in the part which has been taken from the intestine. Right. So I hope we have arrived to the answer of this question, question 6. That is, in Hirschsprung disease, there is failure of migration of the neuronal crest. Okay. Right. Moving on to the next question. Okay. So this is also related to Hirschsprung disease. Again, I have kept this question here so that you can understand the relation and yet the difference between the kind of question they ask from the same topic. Okay. So here they're asking Hirschsprung disease pathophysiology is about option A says cholinergic activity decreases throughout large bowel. Option B says absent myenteric and submucosal plexus in the large bowel. Option C says cholinergic inhibitory activity predominates over excitatory adrenergic in control of smooth muscle tone. No. And option D says innervation is patchy throughout large bowel. Control of smooth muscle is predominantly intrinsic. No. So the answer to this question is quite clear. We have discussed this, that there is absence of myenteric and submucosal plexus in the large bowel. Okay. So yes, this is clearing concept about a disease condition, help you through all the questions that are being asked from the same topic. Right. So question 8, moving to question 8, we have levetiracetam mechanism of action. Now see, this is again a very favorite question and very important question of TAS. And let's see what the option says. Option A says modulation of synaptic neurotransmitter release through binding to synaptic vesicle protein, that is SV2A. Okay, SV2A is synaptic vesicle protein A. Okay. Second option says it inhibits GABA. Okay, and then the option C says it inhibits calcium channels, and option D says sodium channel voltage gated channel. They act on sodium channels. No, and option E says it blocks GABA receptor. Okay, right. So let's come to this table. Okay, and this is right from my notes of TAS, and this is a very, very important table. Trust me, guys, this is really important because this time they're asking you levetiracetam, next time they'll be asking you gabapentin, and then maybe topiramate, and then maybe phenytoin. So all the AEDs are very important, and when it comes to their mechanism of action. Okay, so let's see. Sodium blockers, they mainly include phenytoin, carbamazepine, and lamotrigine. Okay, calcium blockers mostly includes ethosuximide and gabapentin. Then increasing GABA-mediated calcium channel opening is the mechanism of action of benzodiazepines and phenobarbs. Okay, and then increasing GABA turnover is the mechanism of action of vigabatrin. And then we have calcium channel blocker, carbonic anhydrase blocker, sodium channel blocker, GABA stimulator, and glutamate inhibitor, that is topiramate. Okay, so most of the anti-epileptic drugs have multiple mechanism of action, and here I have enlisted the most important ones. But you can see topiramate has like quite many channels on which they are acting. So make sure that you remember calcium channel blocker and carbonic anhydrase blocker for topiramate. Okay, and about GABA and glutamate, just remember that glutamate is stimulatory. Okay, so for any drug which helps us to stop seizures has to inhibit glutamate. Okay, glutamate stimulates, so we have to suppress glutamate, and GABA receptors are inhibitory, so you have to promote them. You have to promote GABA and inhibit glutamate. Hence any AED will, if it is acting on glutamate, it will be stopping its effect. And if it is acting on GABA, it will be, promoting its action. Okay, I hope you are clear with that. So yes, this was about topiramate. And then we have SV82 binder, that is levetiracetam. Okay, so this is what our answer is. And then I have a note written below, that is sodium valproate and topiramate. They have multiple mechanism of action, and this applies for other drugs also. But knowing this table will help you reach to most of the questions. Okay, reach to most of the questions that are being asked in TS exam. Okay, so the answer to question number 8 is A, modulation of synaptic neurotransmitter release through binding to SV2A receptor. This is about levetiracetam. Okay, right. Moving on to question 9, which type of insulin has the longest duration? Okay, so insulin, diabetes mellitus, these are important these are very commonly asked questions. And this is a factual, question. You just have to remember this table, this classification of insulin to reach this answer. So we have short acting insulin, we have rapid acting insulin, we have intermediate acting, long acting, and ultra long acting. So in ultra short acting, we have Lispro, Aspart, and Glulysin. In rapid, we have regular insulin. In intermediate acting insulin, we have NPH. And in long acting, we have Detamil and Glargine. Whereas ultra long acting includes D-Gludec. Okay. So D-Gludec has the longest duration of action. Okay. And this classification also helps us combining insulin for our basal bolus regimen. Okay. Basal bolus regimen will involve bolus of short acting drug and maintaining a basal range with a long acting drug. So this is why we combine Lispro with Glargine or Aspart with Glargine to treat our patients of diabetes mellitus type 1. So the answer to question 9 is D-Gludec. Option D, D-Gludec. Okay. It was about the insulin having longest duration of action. Right. So moving on to question 10, what is the part of eye that originates from the ectoderm? So yes, anatomy and especially embryology is an important part where TS exam assesses you. And hence, this is a question to you from ophthalmology. Okay. Right. So we have been given the word ectoderm. Okay. So now let's come to this diagram, which is from your Science of Pediatrics. It is about stages of eye development. And yeah. So yes, this diagrams help you see that we have ectoderm, then we have neuroectoderm and mesenchyme, which eventually takes the shape of the eye. And yes, eventually they form different parts. That is, from neuroectoderm, we have retina and optic nerve. And from the surrounding mesenchyme, we have hyaloid vasculature, vitreous, and we have inner layers of the cornea. Okay, so this is just to give you a picture view of the embryology, but let's make it a little simple with these tables given to you. Okay, if you remember these tables, you will be able to solve questions related to embryology of eye very easily. So this includes everything, and that's all you need to know about embryology of eye. So from surface ectoderm, see, whenever they say ectoderm, it means surface ectoderm. Okay, and because if they have to ask about neuroectoderm, they will definitely mention the term neuroectoderm. So in this question, the recall which most of the students gave was that the word ectoderm was mentioned and not neuroectoderm. So we take it as surface ectoderm, and surface ectoderm develops lens, it develops eyelid skin and epithelium of the cornea and the lacrimal glands. Whereas the neuroectoderm, it gives rise to retina, optic nerve, muscles of the iris, epithelium of the iris, and ciliary body. Okay. Now, the mesoderm gives rise to extraocular muscles, endothelium of the blood vessels, and sclera. Whereas the neural crest, okay, don't get confused between neuroectoderm and neural crest. Neural crest is a separate entity and it gives rise to cornea, specifically the stroma and the endothelium part of cornea. Because remember, the epithelium of cornea was from surface ectoderm. Okay, so cornea has its origin from surface ectoderm and neural crest both. Okay, also neural crest gives rise to sclera. Okay, so sclera also has its origin from the mesoderm and neural crest. Then neural crest also gives rise to ciliary muscles, ciliary ganglion, melanocytes. Okay, so yes, that's about embryology of eye. So our question 10, which part of the eye originates from ectoderm? They are talking about surface ectoderm. We have corneal epithelium. Okay, corneal epithelium is from surface ectoderm, and corneal endothelium, okay, corneal endothelium and stroma is from neural crest. Right. Then we have iris. Iris develops from, yeah, anyone? So iris develops from the neuroectoderm, and retina, optic nerve, and ciliary body. These also develop from the neuroectoderm. Okay, right. So that was about question 10. Okay, now about question 11, we have a 7-year-old girl presenting to the clinic during examination, whereby that girl had puberty and the TAS stage showed B3 and PH2. Which hormone initiated? Okay, so a 7-year-old girl presented to the clinic during examination, found at puberty, TAS stage of B3 and PH2. Which hormone initiated puberty? So this is a question related to puberty, and they are talking about TAS staging. So here you have picture of TAS staging, whereby in females, they are staged based on the breast development and based on the pubic hair changes, whereas males are staged based on their genital and pubic hair changes. Okay, so this is the stage, the TAS stages, which is given to you from 1 to 5. Okay. So understand in this case that it is a case of precocious puberty because you are given a girl of 7 years of age who has breast development of post-pubertal type. Okay, here you can see in question they have given B3 and PH2. Okay, that is the baby, the girl is having breast development of stage 3 and pubic hairs development of stage 2. Okay, that is quite developed according to baby's age. So this becomes a case of precocious puberty, which is defined as breast development or pubic hair development in girls before the age of 8 years, and or signs of testicular volume increase to at least 4 ml, or other evidence of virilization in boys occurring before the age of 9 years. Okay, so this is the definition of precocious puberty, and we are dealing with the case of precocious puberty in our question. Then they are asking in the question that what has initiated puberty in this case. Okay, right. So this is a very, very important diagram which has been given to you in your Science of Pediatrics, okay, and also in illustrated textbook, which shows there are 2 different kinds of precocious puberty. Like there are 2 different causes. One which is gonadotropin dependent, and the other which is gonadotropin independent. Okay, so in a normal baby, in a normal child, we have gonadotropin releasing hormone which stimulates your LH and FSH, which leads to the development of puberty. But in case of precocious puberty, if there is increase or early release of gonadotropin releasing hormone, which is ultimately increasing LH and FSH, which in turn is secreting estrogen from ovaries and testosterone, and leading to development of testes and adrenals and breast development. This is called as gonadotropin dependent precocious puberty or central precocious puberty. And here you have been given the examples of it. It can either be idiopathic or familial, or it can be CNS abnormalities, or it can be due to hypothyroidism, and so on. Okay. Whereas on the other side, you have gonadotropin independent precocious puberty, whereby it is not the gonadotropin releasing hormone or FSH or LH that is leading to increase or early puberty. It is because of out of the CNS, okay, in the periphery, if there is increase in the production of estrogen or testosterone, which may be due to any ovarian tumor, or it may be due to any testicular tumor, or it may be due to the adrenal disorder. Okay, we know that the adrenal gland, it produces mineralocorticoids, it produces glucocorticoids, and it also produces sex steroids. Okay, so even if there is any adrenal gland tumor or congenital adrenal hyperplasia, there will be increase in the sex steroids, leading to gonadotropin independent precocious puberty. I hope this is clear to you, okay? So here, these estrogen and testosterone and the sex steroids, they increase in amount despite increase in gonadotropin releasing hormone, okay? So these are the two types of precocious puberty. So right, about normal puberty, let's talk about what puberty actually is. So it is a process through which a child passes to achieve sexual maturity and reproductive capacity. And the pubertal onset is precipitated by secretion of the hypothalamic pulses of the gonadotropin releasing hormone, that is GnRH, that I told you about. And this in turn stimulates pulses of LH, right? Okay, so coming back to the question, the question has given you a scenario of precocious puberty, and then they're asking you which hormone initiated the puberty. So there is no clear demarcation if it is a central cause or a peripheral cause, but at the end of the day, they are asking which hormone initiated puberty, okay? So because this is a not very good recall, but still you can safely mark the answer of gonadotropin releasing hormone in this, okay? This was a little controversial recall, and there was quite a debate on it, but most of the people have, agreed with the option C, that is gonadotropin releasing hormone, as the answer to this question, because at the end of the day, any puberty is initiated due to this hormone, okay? But yes, eventually, if you are given a scenario, clearly, if it is a case of peripheral or non-gonadotropin releasing hormone dependent precocious puberty, then the answer might be estrogen and testosterone also. But yes, because they have not mentioned it clearly, we'll safely mark gonadotropin releasing hormone for question 11. Moving on to question 12, a 14-year-old boy with severe acne, what is the pathophysiology of the acne? Okay, so this is a question from dermatology, and most of the times they give us pictures also, but this question was without picture and they have asked about the pathophysiology. So let's talk about acne. So acne vulgaris is a chronic inflammatory disease of the pilosebaceous unit. Okay, remember the word pilosebaceous unit. And 4 pathogenic factors have been described to cause acne, and it includes, first, there is comatogenesis due to follicular hyperkeratinization. And we have second step, that is sebaceous hyperplasia. And then comes increased sebum production. And after all this, there is hypercolonization of Propionibacterium acne, okay, P. acne. And this P. acne is a gram-positive and an anaerobic bacteria, which plays an important role in inflammation in case of acne. Okay, so these are the 4 major steps which are there behind acne. Okay, so let's go back to the question and see. There is excessive sweating? No, there is no excessive sweating. There is excessive production of the sebum. So option B, decreased sebum production? No, there is increase in the production. Option C, follicular hyperkeratinization? Yes, this option is right. So question till 12, option C, okay? Option C is the answer. And then option D says colonization of the Corynebacterium species bacteria in the hair follicle? No. It is P. acne, okay? P. acne is involved in inflammation in case of acne, okay? So option D was also wrong. Right. Moving on to question 13. During sleep in a normal child, how body responds to hypoxia? Okay, so this question is from respiratory system, and you have been given different centers of respiration, and what they are asking you in a normal child during sleep, how the body responds to hypoxia, that is decrease in the PO2 in the blood circulation. So this diagram shows you different centers of respiration, different controls of respiration in a normal human being. So first you have central neural control, that is respiratory drive. Then you have sensory input system, And this sensory input system, basically, it impacts the rate and the depth of the respiration. And it involves mechanoreceptors, metaboreceptors, peripheral chemoreceptors, and central chemoreceptors. And then you have respiratory muscles and lungs, and they carry out the mechanism of respiration. Okay, that is, it includes diaphragm, lungs, external intercostal muscles, and abdominal muscles. Okay, so in case of hypoxia, there is decrease in the partial pressure of arterial oxygen. Okay, so that decrease in the partial pressure of arterial oxygen level is basically stimulating a center. Okay, and they want the name of that center. So let's look at the thing which we have in sensory input system. We have mechanoreceptors, metaboreceptors, and peripheral chemoreceptors, and central chemoreceptors. So peripheral chemoreceptors are the one that monitor the partial pressure of arterial oxygen in the blood and responds to the hypercapnia or acidosis. Okay, so in case of a normal respiration that is occurring during sleep, when there is decrease in the voluntary respiration, okay, at that time, the decrease in partial pressure of oxygen in the blood levels stimulates the peripheral chemoreceptors, which includes carotid body chemoreceptors. Okay, so answer B is correct for question 13. Carotid body chemoreceptor is the answer for question 13. Okay, because if you see the other options, we have option A, medullary receptor center, which is basically a center system of respiration, and they do not respond to decrease in the partial pressure of oxygen. Then we have option C, which says diaphragmatic vagal nerve sensation. No. Option D, chest wall receptor and laryngeal receptor. Chest wall receptor and laryngeal receptors are respiratory muscles which help in respiration. Okay, you can see the diagram which is given in the lower side. So they are not responsible for responding to decrease in the partial pressure of oxygen. This is job of peripheral chemoreceptors, which includes carotid body chemoreceptor. Hence, option B is the answer for question 13. Okay, right. Moving on to question 14, which of the following bacteria is attacked by T-cell mediated immunity? Okay, so this is a question from immunology, and they want to know that which of the following bacteria is managed by or killed by or attacked by T-cell mediated immunity. So you have this table here, which is a very important table, and I have made this table after compiling a lot of information, like a lot of information which was given in different books and internet. And so yes, B cell receptor, that is humoral immunity, responds to extracellular bacteria, which includes Streptococcus pneumoniae, H. influenza, and it also responds to Giardia lamblia and enterovirus. Okay, so this is about B cell or humoral immunity. Then comes to cellular immunity, T cell. It responds to infection of virus, most of the virus. Okay, but out of all the virus, enterovirus is acted upon by B cells. Okay, remember that. And then also T cells acts on fungi and most of the protozoa, and also Pneumocystis cardi and Toxoplasma. And it also acts on intracellular bacteria and Mycobacterium. Okay, so Mycobacterium avium or Mycobacterium tuberculosis, all of these are acted upon by cellular immunity, that is T cell immunity. Okay, then there is another kind of immunity, that is phagocytic killing. This acts upon the fungi and some of the bacteria which have low virulence. Okay, and then there is complement mediated immunity, which mostly acts on encapsulated bacteria and especially Neisseria. Okay, so this is one such table which helps you fetch this answer. Moreover, this is also helpful to you when a question from primary immunodeficiency is asked. So if you are given a scenario where you are being asked about a condition, primary immunodeficiency, which involves mainly deficiency of complement mediated immunity, and you are given some of the organisms which are more likely to attack in those conditions. So there also this table will be helpful for you. So any primary immunodeficiency which has lack of complement mediated immunity, there encapsulated bacteria will be attacking more, and there will also be infection of Neisseria. Okay, right. So the answer to question 14 is option A, mycobacteria. Okay, I hope you are clear with this. Okay. Now coming to question 15, toxic shock syndrome. What is the mechanism of action of the toxin? Okay, so in this recall, only three options were mentioned. So I have kept it that way. I have not added anything from my side. So yes, you are given the option of B cell, activation of T cells, and activation of macrophages. So toxic shock syndrome, what is it? Let's see. It results from toxins produced by Staphylococcus aureus bacteria, and the condition may be caused by toxins produced by group A Streptococcus also. So mostly toxic shock syndrome is due to toxins from Staphylococcus, but group A Streptococcus also leads to toxic shock syndrome. Okay, and what are the risk factors for this TSS? Is skin wounds, surgery, and the use of tampons. Okay, and other devices such as menstrual cup and contraceptive sponges and diaphragms. Then there is bacterial toxins. These are basically bacterial toxins which act as super antigens. Okay, and these super antigens, they activate very large amount of T cells and they generate an overwhelming immune mediated cytokine avalanche, which manifests clinically as fever, rashes, shock, and rapidly progressive multiple organ failure. So this is about toxic shock syndrome. Okay, so these toxins basically act as super antigens, which in turn activates T cell. Okay, and then eventually there is a lot of cytokines released into the body. So the answer to question 15 is option B, activation of T cells. Okay, here the organism is not acting directly. The toxin produced by the organism is acting, and hence they are activating T cells. Okay, had it been only Staph aureus or group A Streptococcus, they would have activated B cells because they are extracellular bacteria. But here in toxic shock syndrome, basically the toxin is the main culprit and they activate T cells. Right. Moving on to question 16. What commonest among children associated with HLA B27? So you have been given this HLA, that is HLA B27, and what condition it is most commonly seen in has been asked. So this is a factual question, and it has been asked around 3 to 4 times in past 5 years in different settings, and different conditions have been asked, different HLAs have been asked. Okay, so you need to remember this table. There is a long list of HLA and the associated conditions which is available in multiple sources, but I have picked up some of the important conditions which have been assessed in the last 5 to 6 years. Okay, altogether I have done all the homework and given you in the form of this table. You just have to remember these conditions and it will help you answer all the questions they ask about HLA. Okay, so yes, you have HLA DQ2 and HLA DQ8, which is associated with celiac disease. HLA DR3 and HLA DR4 are associated with diabetes mellitus type 1. See, understand the fact that these are not the only HLAs associated with these conditions. There are other HLAs as well, but these are the important ones. Okay, these are the important ones and they are the most commonly associated ones. Hence, we are learning these for now. And then there is HLA B27, which is associated with enthesitis-related arthritis, which also includes ankylosing spondylitis. And HLA B27 is also seen in Reiter syndrome. HLA B8 is associated with Graves' disease, SLE, and Addison's disease. And HLA B7 is associated with multiple sclerosis. Okay, so just remember this table and you're good to go for all the questions that are being asked about these HLA genetic factors. Okay. So the answer to your question 16 is option D, that is enthesitis related arthritis, which is associated with HLA-D27. Okay, right. So moving on to question 17, that is morphine mechanism of action. So in this question, they have given mechanism of action, but this is how the recall was framed. But if you see exactly, they have basically given you the mechanism of metabolism in the option, that is conjugation and glucuronidation, sulfation. These are, different modes or different ways of metabolism that a drug undergoes through. Okay, so, but yes, this is how the recall was given. So just let's see about morphine. This is, a mnemonic that I made for myself about morphine, that is like morphine CVS, okay? Morphine CVS, right? So let's see what it says. Morphine is basically an opioid analgesic, and it stimulates mu receptor, kappa receptor, and delta receptors present in the body, and it inhibits pain perception and acts as analgesic. Okay, so basically the mechanism of action of morphine is stimulation of mu, kappa, and delta receptor. Okay, that becomes the mechanism of action. And what are the actions that we see of this drug is it causes meiosis, it gives analgesic effect, it causes respiratory depression, it also causes physical and psychological dependence, it leads to histamine release, and it also leads to hypotension, it causes itching, nausea, euphoria. And it is also used as a cough suppressant, but it has a side effect of constipation. So C stands for cough suppressant and constipation, and V is for vagal stimulation, which ultimately leads to bradycardia, and S is for sedation. So it is morphine CVS, if you can remember it that way. Okay, right. So yes, coming back to this question, like morphine basically is metabolized through glucuronidation. Okay, so this is something you'll have to remember, that morphine has its metabolism through glucuronidation, and hence the option C becomes the correct answer for this question. Okay, right. These are other things about morphine that you need to know, which have been asked and can be asked in future. Right. Moving on to question 18, a child who is 2 years old with coryzal illness, stridor and barking cough, and no drooling. Which organism responsible for this illness? Okay. So there is coryzal illness, there is stridor, and there is barking cough, but there is no drooling. They have specifically mentioned there is no drooling. Okay. This is very important. So the options given to you are parainfluenza virus, Haemophilus influenza, RSV, and diphtheria. Okay, right. So coming to this table, again, I have made this table after referring your illustrated textbook and your SOP and other important sources of resources of MRCPCH, and have comprised it for you. This is all you need to know about the infections that are asked from your respiratory system. Okay, right. So first of all, you have otitis media. The clinical scenario can be given to you in form of earache or ear discharge, and the organisms involved are Streptococcus pneumoniae and H. influenza, Moraxella catarrhalis, and some viruses. Okay. Then you have croup. Croup presents in the form of barking cough, hoarseness of voice, harsh stridor, and variable degree of dyspnea. And what are the organisms involved? Parainfluenza virus, RSV, and rhinovirus. See, I have highlighted parainfluenza virus because it is the most common cause of croup. Okay, right. Then you have acute epiglottitis. It presents in form of high-grade fever, drooling of saliva, and the child is very toxic looking. Okay, and there is difficulty in breathing. So these babies, you can just look at them and tell that these are the cases. This is the case of acute epiglottitis, because they are so sick looking. And it is a very emergency condition. You have to manage it, immediately, or else it might lead to mortality. Okay, so organism involved is H. influenzae B. Okay, then you have bacterial tracheitis, also known as pseudomembranous croup. It presents similar to acute epiglottitis, that is, it has high-grade fever and difficulty in breathing. and the organism involved is Staphylococcus aureus. Do not worry much about differentiating between acute epiglottitis and bacterial tracheitis. They won't be judging you so much for your clinical, clinical skills for these two scenarios at least. Okay, they'll be giving only one thing in the option if such thing they have to include. Okay, but yeah, drooling of saliva is related to acute epiglottitis is a very commonly given scenario when they are talking about this condition. Okay, then you have bronchiolitis. It has coryzal symptoms, dry cough, breathlessness, and there is hyperinflation of chest. Okay, in the chest X-ray also you can see changes of hyperinflation, and on examination, on auscultation, you can hear wheeze in case of bronchiolitis. And the common cause includes RSV virus, parainfluenza virus, rhinovirus, and adenovirus. Okay, I have highlighted RSV because it is the most common cause of bronchiolitis. Then you have common cold, which has mild fever and coryzal symptoms. Most common cause is rhinovirus. And then there is diphtheria. Diphtheria, again, is an emergency condition. It presents as fever. It can be mild fever or high-grade fever. And then there is weakness, sore throat, swollen glands in the neck. And on examination, you can see pseudomembrane. It can either be present in the pharynx, or it can even be present in the nasal pathway. And sometimes it does extend up to larynx. Okay, we call it as laryngeal diphtheria. And it is again emergency and deadly condition. And the organism which causes it is Corynebacterium diphtherium. Okay. So coming back to the question that we have, so this is the table which is important when it comes to infection in respiratory system, and this includes everything. Okay, if you learn this table, you can solve most of the question of TAS and even FOP. Okay, because it includes clinical features also. You can make diagnosis based on these clinical features given to you. Okay, right. So the question says coryzal illness, stridor, barking cough, and no drooling. So we have ruled out acute epiglottitis, and stridor and barking cough is seen in case of croup. Okay, and option A, that is parainfluenza virus, becomes the most important cause of croup. Hence, option A is the correct answer for question 18. Okay, right. Moving on to question 19, we have a 14-year-old child. They have not mentioned if it is a girl or a boy. Who is a runner presented with acute limb pain, hemarthrosis, and prolonged TTT. Okay. And the option given to you is factor 7, factor 9, factor 2, and factor 10. So let's see how can we solve this question. So this is a table taken from your Science of Pediatrics. First of all, we have been mentioned in the first table, we have 3 tests, that is PT, APTT, TT of fibrinogen given to you. And then you have been given what pathway of coagulation they basically measure, or they are a reflection like PT. The test PT is a reflection of extrinsic and common coagulation pathway, whereas APTT is a reflection of intrinsic and common coagulation pathway. And then you have the responsible clotting factors given on the third column, which is PT will basically measure your function of factor 2, 5, 7, and 10, whereas APTT will measure function of factor 2, 5, 8, 9, 10, 11, and 12. Okay, so second table will tell you if you have a condition where there is high PT, normal APTT, there is basically defect in the extrinsic pathway, and defect in only PT and not common pathway, not APTT, will signify that there is factor 7 deficiency, okay, or that there is warfarin treatment going on. In conditions where you have high APTT and normal PT, there is basically problem with the intrinsic pathway, and it is seen in hemophilia A and hemophilia B. It is also seen in factor 11 and 12 deficiency, von Willebrand disease, lupus anticoagulant, and heparin treatment. And for conditions which have high PT and high APTT, there is disruption of the common pathway. Hence, the problem can be with factor 2 or factor 5 or factor 10 deficiency. And it can also be seen in fibrinogen deficiency, vitamin K deficiency, and also DIC. Okay, DIC. So in the question, in the recall that was provided to, that was provided by the students, they mentioned that there is prolonged PT, but there was nothing specifically mentioned about the APTT. Okay, and hence factor 7 would be the answer for your question 19. Okay, so answer A, option A, factor 7 is the answer to question 19. I hope you understood how are these tables so important to arrive to the answer of the question that was given. Okay, right. So coming to question 20th, which is the last question, it says, what causes left to right shunt through foramen ovale after cord clamping cardiology? Okay, so after cord clamping, that is after a baby is born, what are the changes that happens in the fetal circulation is a very important topic. And they ask it almost every time. It is a very, very important subtopic of cardiology, and we must know it clearly. So let's see the circulatory changes at birth. So in the fetus, the left atrial pressure is low because there is relatively less blood which is returning from the lungs. We know that there is no, the lung is not the main source of oxygenation in a fetus, and it is basically, the oxygenated blood comes from the mother through placenta. Hence, because there is no much return from the blood vessels which return from the lung to left atrium, the left atrial pressure is low. The pressure in the right atrium is high in a fetus than in the left, as it receives all the systemic venous return, including blood from the placenta. I hope the statement is clear to you. And the flap valve of the foramen ovale is held open in a fetus because the blood flows across the atrial septum into the left atrium. So blood flows from right atrium to left atrium in a fetus, and then into the left ventricle, which in turn pumps it into the upper body. So this is what happens in a fetal circulation. But after the first breath, what are the changes that happen after first breath? First, the resistance to pulmonary blood flow falls because the baby breathes in oxygen. The oxygen helps in dilatation of the pulmonary vasculature. Okay, pulmonary vasculature dilates in response to oxygenation, and hence the resistance to pulmonary blood flow falls. Second, the volume of the blood flowing through the lung increases sixfold. Initially, there was no oxygenation happening in the lung, but now because there is dilatation of pulmonary blood vessels, a lot of blood is flowing into the lung, and the oxygenation center now becomes lung for the baby. Okay, right. Then third step is this. The entire thing that we have seen first and the second step results in rise in the left atrial pressure. That is, now more blood is flowing into the lung and more blood is returning into the left atrial pressure, left atrium, hence increasing its pressure. Then the fourth thing that is happening is the volume of the blood returning to the right atrium falls as the placenta is excluded from the circulation. So the placenta is removed, and now the blood that comes back to the right atrium reduces relatively. Yes, so that's what basically changes during the birth. Now coming back to the question, which is asking what causes left to right shunt through foramen ovale after cord clamping cardiology. Usually when there is the foramen ovale is not patent, the valve gets shut, as the left atrial pressure increases and the right atrial pressure falls, the flap is closed, and hence the blood does not flow from the left atrium to right atrium. But when there is patent foramen ovale, when the foramen ovale, there is no proper flap in between, the blood will flow from left atrium to right atrium after cord clamping. Okay, and what will cause that? We have option A, which says pulmonary vasodilatation. Option B says increase of systemic resistance. So increase of systemic resistance is not leading to this change. Okay, this change is basically happening because there is increase in the left atrial pressure. And that is because of more blood coming into the left atrium from the lung, which is because of pulmonary vasodilatation. Okay, so option A is right. Let's see option C also. It says increase right atrial pressure. No, right atrial pressure is not increasing after the baby is born. It rather decreases. And then we have placental circulation interruption. See, placental circulation does interrupt, but that leads to fall in the pressure of right atrial pressure, okay, and not rather increase in the left atrial pressure. Right. So this phenomena is happening due to increase in the left atrial pressure, which in turn is happening due to pulmonary vasodilatation, which leads to increased blood flowing into the lung and increase in the blood which is flowing from lung to left atrium. Okay, I hope it is clear to you now. Right. This was all about this session, which includes question from TAS, which are all recall based, and it covers most of the topics that we have in our syllabus. And right. Any queries? You can also write it in the chat box if you want. Okay, I guess there are no queries.